Hi, I'm Jessica, and today I wanted to do a quick walkthrough of what a speech sound assessment can look like. As you might already know from my other videos, I love my templates. Before I see a new client, I review their file and see if they've had a previous assessment, and I see if there's any medical documentation to give me an idea of what I can expect. Importantly, I need to know how old the kid is so that I can prepare with appropriate activities, materials, and assessments. I look at any previous assessment findings. I get any referral information. Why are they coming to see me? And I get general background information like who does the client live with? Do they have any siblings? Are there any other languages spoken at home? Is the child aware of their speech sound difficulties? And if so, does it bother them? Do they become frustrated when they can't make themselves understood? Do they have any atypical emotional or behavioral difficulties? And are there any other family members who have had speech or language difficulties? I found this list of red flags from Linguasystems Guide to Communication Milestones. So I go through and check some communication milestones, highlighting or bolding any significant indicators that can help me formulate my clinical impressions. Next, I look into the child's medical history. Do they receive any other services like occupational therapy or physiotherapy? Are they on any medications? Were there any difficulties with pregnancy or birth? Were there any difficulties with the development of their chewing, feeding, or swallowing skills, as all of those are related to her speech sound muscles? Were there any delays in meeting other physical milestones, like gross motor skills for walking, running, standing up, etc.? Do they currently have any difficulties with walking, running, or fine motor skills, like drawing or grasping scissors? Do they have any documented medical diagnoses? Do they have a history of recurrent ear infections? Do they have any sensitivities to noise, light, or texture? Have they had any surgeries? Have they had any chronic colds or infections? And are there any difficulties with vision, pain, or fatigue? I then need to know about their academic information, such as what grade are they in? Do they have an individualized education plan? What are their best subjects at school? And what are their most difficult subjects at school? Do they have any school services? And are they involved in any extracurricular activities like sports or creative endeavors? I want to highlight this question, asking the parent or caregiver to describe their child's personality to me. I really like to ask this question because it helps me know how I can connect best with the child during the assessment to make them feel comfortable and increase the likelihood that I'll get more of a language sample from them so I can really have a good idea of what their speech sounds are. I also like to get a sense from the parents, what are their particular interests? Sometimes I ask the kids directly, but often they don't necessarily know how to answer if they're very, very young. But the parents will often tell me they like Peppa Pig or Paw Patrol or Mario or dinosaurs, or they're super into tools and building things. Understanding their personality and interests again lets me know how when I get on the floor to work with the kiddos, how I can best make them feel comfortable and interested and motivated to talk to me. The next part of the assessment includes formal and informal assessment measures. So at my clinic, we use the Chia, which is a story about a little boy who goes to the zoo. The story only has pictures, and first I say the sentence, and then I get the kid to repeat the sentence after me. This gives me a really quick, structured way to check for speech sound errors while minimizing the amount of transcribing or writing that I have to do. After I get my scores from the Chia, I get on the floor and I engage in free play with the kid. I try to engage them in conversation either about what they're playing with, or I ask them personal questions about what's your favorite food, or do you have any pets? And based off of their responses, I can make the following observations. Do they readily engage with me, or do they prefer parallel play and to follow their own agenda? Do they make appropriate turn taking? How much eye contact are they making? Are the responses they give on topic and related to what I'm saying? Can they join me in imagination play? Will they help me create rules for games? How do they communicate? Is it with picture exchange systems? Is it with an augmentative and alternative communication board? Is it verbally with gestures, sign language, etc.? Stimulability. This means, can I get them to produce the target sound correctly? And finally, I take a language sample. So as I am playing with them, I am writing in IPA transcription. So these are specialized symbols that are used to represent the different sounds of all languages, but obviously I only stick to the English sounds. I also like to ask parents, how would they rate their child's ability to be understood or intelligibility, where 1 means completely intelligible and 5 is you can't understand anything they're saying. So I get parents to rate how well they understand their own child, but I also get parents to estimate how well strangers understand their child. The next section is based off of my prompt training, which was a 3-day workshop, and it is a different way to examine speech sound errors based off of motor speech hierarchies. So this table, the system analysis observation, is based off of the prompt format. And so this is what I'm looking for. Is their face symmetrical? Are the upper and lower jaws in alignment? Do they have an appropriate height for their teeth? When they smile, is there any misalignment or overjet or overbite that might need correction to help them fix their speech sounds? And at the roof of their mouth, do they have any clefts or gaps? Next, I'm looking at their tone, their muscle tone in their body and face. So I can only signify that this is a problem if a diagnosis has already been made. If there's no formal diagnosis, I have to say it's within normal limits, but I can make comments here. For example, this might warrant further exploration. I also check to see if their reflexes are inhibited. For example, if you touch near their mouth, infants have a rooting reflex, and so they're going to try to get at your finger because they think it's food. The first level in terms of motor speech that I'm looking for is, can they get 1 to 3 seconds of voicing? In other words, can this system valve for speech? Do they have enough control over their breath and their vocal folds and the coordination of both of them to get voicing? Not only that, but we have some sounds that use our voice and some sounds that don't use our voice. For example, the P sound has no voice. So if you put your finger here, you will not feel buzzing when you say p, p. Now to get a B sound, you turn on your voice, so you should feel the buzzing. B, b, b. So that's an example of, can this client control voicing for voiced and voiceless sounds? This one is checking, do they sound like too much air is flowing out of their nose or not enough air is flowing out of their nose? Hypernasality means there's too much air.
So it sounds like this. There's not enough intraoral air pressure for the sound to come out clearly.
There's not enough air pressure in the mouth for the sounds to come out clearly if the muscle at the back isn't tightly closed. Conversely, hyponasality is when either this is not open or maybe there's sinus issues. So air cannot come out the nose, and that means you sound more stuffed up, as if you have a cold. Stage 3 in the motor speech hierarchy is looking at jaw range of motion, which is down and up. So if a kid is not consistently getting that last sound at the end of words and it's a consonant, for example, cat, they might say ka, or dog, they might say daw. That tells me that their jaw doesn't know that it has to come back up to finish the word. With their jaw, I'm also looking when it's opening and closing during vowels. Is there any sliding, like or is it keeping to the midline? The fourth stage of the motor speech hierarchy is the lips and face, or labiofacial muscles. Interestingly, native English speakers only use the middle third of their lip when producing bilabials, p, b, and and that maximizes the efficiency with which we're saying those sounds. So is the kid efficiently using their lips, or is it over exaggerated, like p, b, That's not efficient. Do they need their chin or their jaw to help their lips open and close? Are they able to isolate the lip movement for the F sound, like in fun or in frog? Or are they relying on support from the jaw to help them get that? How are their cheek muscles? Do they have enough smiling when they're saying their E or A sounds? Or are they smiling too much so that when they're trying to say the word shoe, which needs round lips, it's coming out more like sue, sue? It doesn't sound right because they are too retracted. Conversely, how efficient is their ability to round their lips for shoe? Stage 5 is the tongue, and that is the forward and backwards plane of movement. So we look at the tip of the tongue, the mid region, the mid back region, and the back region. And there are speech sounds associated with each of those regions of the tongue. In the sixth stage, I'm looking to see how all of those systems integrate with each other. They need to be able to work independently, meaning they don't rely on each other, but they need to be coordinated so that we get our most efficient speech. So in this section, we're looking at things like, can they voice through an entire word, like bed or gone? Can they turn their voice off at the beginning of words, but then turn it on to finish the words, like pig, pad, toad? How are their muscles in connected speech? Is it fluent or is there more groping and effort involved? Importantly, if any of these indicators are within normal limits, then we don't have to see the kid. So we would most of the time mark it as no if they're here for help with their speech sounds. And you can hear that the system isn't accurate yet. And the final thing is, are they able to co-articulate? I want to show you something cool about co-articulation. Say the word seat, seat. Say it again, but this time, pretend as though you're going to finish the word, but only hold on to the S sound. See how my cheeks are smiling? Okay, now say the word soup, soup. Pretend like you're going to say the word soup, but hold on to that first S sound. Now my lips are round. So why are my lips smiling for the S in seat, but round for the S in soup? Lip rounding in that case doesn't change the way the S sounds, but my lips are anticipating the next sound. In seat, the E needs me to smile, and in soup, the oo needs me to have round lips. So even though I'm saying the sound S, my lips are already moving into position for the upcoming sound, and that is co-articulation. So with all these data, I can then see where do they score on that chia. Is it in the mild, moderate, moderate severe, or severe range for the number of errors they make? And what is the percentage of consonants they produced correctly? That percentage corresponds with different age levels, what we would expect the percent consonants correct to be. Finally, after all of that, I integrate all of those results, all of the answers, and I formulate with the parents goals based off the parents' priorities. Importantly, communicative disorders assistants can only do parameter prompts according to the prompt model. So typically, if I know a file is going to a CDA, I will give them more of a traditional articulation approach. If I think a certain client, one, for example, who might have a motor speech disorder like apraxia of speech or ataxia of speech, I would be more inclined to take them onto my caseload so that I could do all three levels of prompt. And the cool thing about prompt is it provides tactile and audio information so that as I'm touching a kid's chin and cheeks to help them with those movements while pairing with the acoustic clue of what the sound is supposed to sound like, even if my client doesn't actually say the correct sound, I'm still rewiring their brain just by giving them the tactile and audio cues, which is pretty neat. So, assuming the traditional articulation approach, these are the sounds I'm looking for if the client is over age 3. These are the sounds I'm looking for if the client is over age 4. These are the sounds I'm looking for if the client is over age 5. I look for all of these if the client is age 6. And finally, I look for all of these sounds if the client is age 7. The other two columns here are for my own personal use. Again, it is my template that I use to just simply indicate, are we working on the kid's ability to hear the difference between sounds? Can they produce the single sound? For example, b, b, b. Can they say it in syllables? Bay, bee, bye, bo, boo. Can they say it in words? Big, ball. Can they say it in phrases? My ball. Can they say it in sentences? Pass my ball, please. Can they do it while reading? And can they finally do it in spontaneous conversation? So we have to pass through this hierarchy: sound, syllable, word, phrase, sentence, conversation. First at the beginning of words, then at the end of words, and then in the middle of words. What kind of cues am I using? Am I using tactile? Do they need an immediate model? Can I give a model and then say something else and then they repeat it accurately? Do they only need modeling occasionally? Do they need any visual cues, or can they do it with no cues at all? And that's what you might expect from a speech sound assessment.